shall go on to our next speaker, Dr. Deepak Megur, heads the Cataract and Glaucoma Department of Megur Eye Hospital at Bidar, Karnataka. And he is probably a rare combination of brilliance and simplicity, and has had received innumerable awards and accolades backing him up. And he is going to take us through the path of dealing explicitly with a runaway rhexis. On to you, Dr. Deepak.
Thank you, Rabuti sir. Thank you, ma'am. Thank you, Team Eye Foundation, for the invite. I'll be talking on the rhexis has run away. Now, what do we do now? To phaco or not to phaco? I think that is my topic. So this is a challenge which we come in day in and day across. Instead of taking the best of the efforts and best of the techniques, we still have the situation where we find ourselves helpless. And what do we do now, whether to switch to manual SICS or phaco? In phacoemulsification, how do we deal with the nucleus? Should we go with the antechamber phaco or in the back division of the nucleus? In this case, few points have made me to decide to go in favor of phaco. So visibility is very good. The pupil is well dilated, and I can see the edge of the flap. And before deciding to do phaco, I think there are certain technical modifications which are mentioned here. Minimal nucleus rotation, key is to maintain the anterior chamber. And most importantly, always try to keep looking at this flap, which has been described by Dr. Rohit Om Prakash. I learned it from him. Basically, it is nothing but, the capsular flap has to be everted and fluttering. That's a good sign. It is an indirect evidence that tear has not yet extended beyond the equator. So as we're doing the surgery, you can see that if you're always having a look at this flap and it's always everted and fluttering, then it's an indirect evidence that you're still in the safe zone. An important tip is, as soon as you have a first quadrant, remove it, because that's going to create some space for us inside the bag. And no rotation. Mind you, there's no rotation until we remove one or two pieces. The critical point here is, once we have enough space, there is less likelihood of inducing tension onto the flap and the bag. And that is going to be critical in ensuring that the tear does not extend beyond the equator. Always prefer to use dispersive OVD because it helps in maintain the equilibrium very well. And in a controlled parameter, most often than not, we get away quite well in spite of having a through and through equatorial extension of the rhexis. Important always to ensure the haptics are perpendicular to your anterior capsular tear. And invariably the results are outstanding and we get this edge. But sometimes we always we'll not be so lucky. So this is a similar situation. I begin the surgery, the flap is still everted. You can see that. I've extended the rhexis a little bit, but what is different here compared to the previous case is that the nucleus is far more bulky, it's far more denser, and I'm stressing a little bit more on dividing the nucleus. After some stage of the surgery, pupil is still well dilated. I can see that the flap here has stopped fluttering, and you can see that it's no longer inverted, it's flat now, or in fact inverted. That is a danger sign. I stop back, put in dispersive and have a look inside. We can see that there is a huge PC tear staring at me under the nucleus. So it's challenging to diagnose a PC tear under the nucleus. That's the reason why we need to have, be careful in understanding this indirect evidence, looking at the anterior flap, how it is behaving. And now the chance, what do I do now? Should I do an AL scaffold or a scleral tunnel incision? In this situation, I shifted superiorly, did a scleral incision, removed the thing. Pars plana anterior vitrectomy was done, and this was how I was looking. And I could manage to place a multi-piece IOL in sulcus. And this is how it is. And the lens was well centered because still I could retain sufficient amount of posterior capsule and anticapsule there. And needless to say, the visual acuity was quite good and the patient was reasonably happy. So the message here would be like, so we have a situation where the rhexis has run off. We should have a clear-cut idea what should be the next plan, Converting to SICS and ECC is not a shame at all. The decision to convert would depend upon the skill level and experience of the surgeon, density of the nucleus, and intraoperative difficulties. How good am I seeing? That's the biggest question I would ask myself. Dealing with a small pupil, hazy cornea, because I want to see the flap which is fluttering. And apart from that, you need to understand the coexisting pathologies like poor corneal endothelial, helm and soda exfoliation, etc. Having decided to go ahead with phacoemulsification, we have got a clear goal here. The goal is to prevent extension of the tear to the posterior capsule. And we need to follow these principles. The secret is in the maintaining the chamber equilibrium. Don't allow the chamber to suddenly deepen or suddenly to shallow here. Use a technique to divide the nucleus to ensure that the stress on the intercapsular tear is at its minimum. And always be ready to abort phaco if situation worsens. There is no role of ego here. And finally, the technical modifications which we need to do here is no hydro procedures, no nucleus rotation, watch out for the flap mobility sign. And after the first division, remove one fragment from inside the bag is going to create more space, which is going to help us to prevent stress on the bag and the tear. And the appropriate bottle height and phaco parameters so that the AC doesn't fluctuate, doesn't go deep suddenly, doesn't shallow also. And lastly, the antocular placed in the bag with haptics oriented 90 degrees to the equatorial extension. And these are the few modifications one can use when you're doing phaco in an eye with an equatorial extension of the anticapsular tear. That's it. Thank you so much for attention, and thank you for the invite.
Thank you so much, Deepak. We can stop. I'm always amazed at the quality of your videos. You know, even internet is not able to diminish it in any way. I think you said it all. Sunpik, any comments?
I just wanted to know if you had one radial run out versus two radial runouts, would it make you change your plan or your approach to the case?
I have had situations in both ways, but in my experience, that has not altered any outcome change. But the biggest the differentiating factor always has been the density and the bulkiness of the nucleus. The more bulkier the nucleus it is, I've had problems of the tear extending. If it is even one tear or two tear, if the nucleus is soft, I usually get away with nothing. But if the nucleus is very bulky, like in some intermittent cataracts, it's hidden inside. Once the cortex comes out, you still have a bulky nucleus. Those are the ones which really be a problem for me.
And would it be different whether your rhexis was small or large? I mean, would it put more stress on your runout area if you had a small rhexis and try to manipulate a huge
absolutely. Because it's imperative that I always extend the, once it has gone radial, always ensure that the rhexis is slightly, whatever remnant of the intercapsule is slightly bigger, because a bigger rhexis is likely to tolerate the stress more compared to a smaller rhexis.
Yeah, so basically you would want to tell us that if you had an Argentinian flag sign, your rhexis shouldn't be too small.
Yes, absolutely.
It would put more stress.
More stress.
Yeah, that's what I agree absolutely.
So your first regarding whether it's runoff in two directions or one, what was it? What was it that indication?
I think it was no difference to him. For me, actually, one runout would be worse.
Yeah.
Because there will be more stress focused there, especially if you have bulky nucleus. Yeah, and of course, if you had a runout on both sides, you want to make the rhexis bigger so that there will be less stress overall.
Can I comment, sir? I mean,
yeah, please go ahead. Please go
okay.
ahead.
You know, I think the quality of video is brilliant. I just wanted to add something which might help. You know, when you have a very bulky nucleus like the one which you showed, I would not like to go for a direct chop, because whatever you might do, you might get the chop very nicely, but the lateral separation to crack the posterior plate is going to be very tough, because that's going to stretch your bag, it's going to stretch the rhexis and may, you know, increase. I would have gone for either a stop and chop or a 4-quadrant crack, because it debulks the nucleus and, you know, the quadrants become much smaller. So if you have a deep, you know, like a good trench, at least one trench, and you've debulked the nucleus, then cracking it and lateral separation becomes so much easier. And a 4-quadrant would not be a bad thing if you had like a really black cataract with a, you know, like an Argentinian flag or a runaway rhexis or whatever. So I think doing a direct chop is great for everything except here, where, you know, this is one thing which I thought I might just add.
I think that's a good point.
If I can add something, Ramu, what's the opinion of the panel on, in such situations, if you can just, with the phaco, lift the nucleus out of the bag and put it back? Maybe, you know, your stress on the capsular bag would be less, where you do supracapsular phaco. These are very typical cases in my hands for a supracapsular phaco, where I just lift it and leave it, so it's back on the capsular, anterior capsule, and then it can continue.
I completely agree with you. You know, the cases, all that he showed was pretty hard cataracts, but If it is a soft cataract that is there, especially when you do a adequate hydro dissection, automatically the nucleus pops out. And if you do all your maneuvers outside the capsular bag, the least amount of stress is there, and most often you have managed to maintain the capsular integrity. And as Dr. Deepak said, I think having a one runoff in one particular direction is sometimes worse than having something like a can opener capsulotomy, because there the stress is uniformly distributed all around here. There's a single point. And sometimes even when it's a small rhexis and there's a runoff, we even tend to nick the capsular rhexis margin, whatever is intact also, so that you create multiple points of discontinuity and the force is not concentrated in one direction.
Just one point of clarification. I mean, I as all junior surgeons, I think we would have this doubt on which technique would actually cause more zonular stress. And I would like the panel to correct me if I'm wrong, but any trenching maneuver, I think, puts more stress on the zonules. So if I were to face with a similar situation, probably what I would do is bury into the center of the nucleus, slightly lollipop it anteriorly so that it is coming out of the leaflets of the capsular rhexis, and use a horizontal chop going to the equator of the nucleus. Because here, especially if the pupil is dilated, reaching the equator of the nucleus is not at all difficult. And all your forces are centripetal when you're doing a horizontal chop, and there is no centrifugal force. Whereas when you're doing trenching and you're dividing, the forces are more centrifugal, and that is when I feel there is a higher likelihood of your rhexis to extend posteriorly. Centripetal forces are less likely to put force on the periphery.
Probably these are the cases where I would use, phaco burst. You just grab it and do horizontal chop.
Yes, sir.
Great.
So I think it's not the chop which really makes the problem. It's the lateral separation, as I was pointing out. So if you're having a little kind of a cataract where a horizontal chop, sometimes in spite of what you might do. But I agree with your point that if you have a machine which is probably not going to do a great job at the trenching, we may end up putting more forces on the posterior capsule by the force of the trench. But if you can use something with Ozil or something with the transverse phaco, and nowadays these machines have excellent tips which can eat through the even the brown nuclei, I would not probably transmit much pressure. But your point is absolutely valid. So you have to see what suits you best, and I think then decide. Rhexis by snipping it, I would rather not snip it, but I would make it larger. I mean, like I would tear it and form, like whatever two bigger rhexis. But you're absolutely right. To decrease the stress, you have to have a much larger capsular opening if you're planning to prolapse, like Dr. Haldipurkar said. If you want to just kind of scoop it and bring it above the supracapsular plane, but for that, if you have a very big nucleus, you might end up just causing the extension of the runway. So you might want to actually enlarge the rhexis on both sides. I would do that, and then like kind of go twice on each side, make it much bigger, like a 6 mm rhexis, and then kind of allow it to prolapse out of the bag rather than try to force it out through a smaller rhexis.
One more quick point to add, as Dr. Ramurthy has mentioned it, if it is a unidirectional tear, it is better we convert it into a multi-directional tear by placing this thing what nicks in the 120 degrees away from the tear. So you can have 3 tears, so the force distributes equally, and chances of rhexis tear extending to the periphery becomes less.
I wonder if anyone would consider the use of a MyLoop in this case.
It's not MyLoop. Any final comments, Titial? I mean, regarding this phaco chop or 4-quadrant stop and chop?
I think very interestingly, nice points are pointed out. But whenever you have an entire bag filled with the intact nucleus, the forces are never transmitted to the tearing area because the bag is completely filled. You can do a trenching, you can do a scalping. It doesn't make a difference to a tear which is there. If you have a subluxation, I can understand. So I would rather, as rightly said by Dr. Gaurav, the hard nucleus is better to do a little bit of trench, and the subsequent chopping can be easier. So I still do a trench and a stop and chop technique there, which makes things simpler. And if you have a hard cataract, if nucleus is mobile, then I don't take out the piece in these cases. I'll do a multiple chops first because the back has to be stable. If the entire nucleus is there, the chances of tilting happening during your chopping is less in these cases. I retain the pieces, do a multiple chop, then take out pieces one by one. And rightly said, don't allow the chamber to collapse. Maybe I can keep using a dispersive viscoelastic from my other side for in these cases to keep the posterior capsule more taut in these cases. And as far as I'm concerned, I've never been a anterior chamber phaco person right from the beginning. I normally don't dislodge these cases, try to maintain the bag as far as possible. But I would still do a, what do you call, making a debulking or making a nucleus, central nucleus softer so they can do a better management in these cases. Rhexis wise, I think the size is important. Larger size will make a little better manipulation with your second instrument in these cases. And rightly pointed out, slow motion phaco, low flow rate. If I'm normally I do in my Centurion, my height is around 50. I'll go down to around 40 or 35 in these cases and do a surgery in these cases.
Great. I think there's still 800 people logged on. Some at
wow.
some point a couple of thousand. So good. I mean, go ahead, Chitra.
You don't feel bad.
Yeah.
No, I'm okay.
You're all there.